Thank you, Lydia. Good evening, everyone. Thank you so much for the opportunity to briefly introduce the GP CanShare program to you all. My name is Simone Ray, and I have the pleasure of running the new GP Cancer Support Line for the GP CanShare service in my capacity as a specialist cancer nurse, clinical nurse consultant. The initiative is a collaboration between the Central Eastern Sydney Primary Health Network, Southeastern Sydney Local Health District, the Sydney LHD and St Vincent's Health Network. It has a focus on enhancing cancer management in primary care and improving communication channels and enhanced information sharing between the primary and acute care settings. With clinical nurse consultants based in cancer centres and hospitals across the region, supporting general practice teams, GPs and practice nurses, now have a link to facilitate a more in-depth shared model of care via our team nurses, including Cassie Golding and Heidi Alfred, who are based at St George campus and also across the Sutherland hospitals. So you can see their contact numbers there, and these nurses are immediately a link straight away to the timely information and cancer management information that you need. Another component to the program is our centralized GP cancer support line. It has been established it may be based at St Vincent's at the Kinghorn Cancer Centre, but is a centralised service covering the regions and districts that I spoke of. We have a phone number that is there, 1800 GP line. We really would like to deliver timely specialist advice and information on a range of topics that you can see on your left there, including treatment and symptom management. I have found a theme of calls that it's really valuable to GPs to have some more information on admissions, discharges, and treatment plans. So our service is available Monday to Friday, 8 a.m. to 6 p.m, including public holidays. And I aim to be a link between myself and the specialist cancer team as a whole, no matter what your inquiry is. So whether you have a general inquiry or a patient-centred inquiry on patient and on cancer and cancer-related palliative care, we'd love to hear from you. Thank you for your time, and I'm sure you'll enjoy the evening.
So tonight we've got a talk on melanoma by Michael Rtshiladze. Just to let you know, Michael is local to the Cogra area, grew up in the Cogra area, and naturally trained in Australia. His training and special interests include skin cancer, melanoma, reconstructive plastic surgery, paediatric plastic surgery, and paediatric craniofacial surgery. He's completed 2 postgraduate fellowships in plastic surgery and was the recipient of the MIA post-fellowship focusing on the surgical management of skin oncology and melanoma. So he's certainly well qualified to speak to us tonight. Did some fellowship years in Toronto as well, and works a faculty member at the Melanoma Institute in North Sydney, as well as working Prince Alfred Hospital, the Children's Hospital as well, and also a VMO of plastic surgery at Prince of Wales, St George Hospital and City Children's Hospital. So he gets around, very well qualified. Pleasure to have him tonight. So what we'll do is the usual format. You can send questions in during the presentation and we'll stop every sort of 10-15 minutes or so and answer some of those questions. So if you're ready, Michael, I'll pass over to you. I can't see you on my screen. There you are. Hello.
Hi, I might.
So whenever you want to get going, we'll
absolutely. Get going. All right. That should be coming up for everyone.
Yep, that looks good.
Fantastic. Good evening, everyone. So thank you for the introduction, Matt. As Matthew said, I work in a number of public hospitals, but for the most part, I consult out of St George Private and operate there. And I also work over at the Melanoma Institute in North Sydney if anyone needs to get a hold of me. Matthew asked me to speak about melanoma management. tonight, and it's certainly a topic that I find myself speaking about often to different groups. There's a great difference in level of comfort that a lot of people have in managing melanomas, and even for people who have had training in managing melanoma, there's this real sense out there amongst a lot of my colleagues that the landscape continues to change very rapidly. And in doing that, it makes people worry sometimes that they would be at risk of falling behind some of the latest updates. So I think people get a lot of comfort out of sessions to make sure that they feel that they're up to date with what's happening. And certainly a lot has changed, even in my brief time moving from a trainee to a fellow to a consultant plastic surgeon. Some of the biggest changes in the last 4 to 5 years are outlined here. And they really have made a big difference in the way we approach melanoma management. We're going to speak today in a very practical sense for the most part about where most primary care setting melanoma management occurs, but underpinning these changes are these things. So we've moved away from NHMRC published national guidelines, which a lot of people were familiar with, towards what we call a wiki guideline, which is hosted by the Cancer Council website, and it's freely available. I encourage anyone who's not logged in and had a look at it to take some time to be aware of that resource. That move to that guideline has allowed that guideline to be updated much more rapidly rather than waiting for complete revisions to be published. And in fact, it allows the authors to, in fact, update individual sections. So again, keeping up with the pace of change that we're seeing. Another big change, certainly in my surgical practice, has been the results of some very large trials, particularly related to sentinel node biopsy, the Mslt2 trial that was the results published in 2018. There's been a change in the staging system in the last few years. We've moved from a 7th edition to an 8th edition. So that actually changes the way we categorize melanoma patients. Every time a new edition of that is released, we're getting more and more clarity about prognosis and different treatment options that are applicable at different stages. So it's always a big breakthrough moving forward. And the big change really that's changed the landscape of treatment is the drug therapy. So the majority of the revolution that's occurring in melanoma management isn't necessarily in the surgical management, but rather in the medical management. And the interesting part becomes for a surgeon or for all of us is how do we interact with these new breakthroughs, and what does it mean for the way that we treat our melanoma patients, even with surgery or with excisions. So what I'd like to cover today is much more of a practical thing, looking at the way those changes have had an impact on practice. Start with some real basic ideas of biopsy, moving on to the wide excision, the really contentious topic of sentinel nodes that causes a lot of, usually generates a lot of questions at that point. And then an important point that's overlooked often is actually what should we all be doing to follow up our patients who've had melanomas in the past? And that's certainly an important role where we all have a role to play. I appreciate that amongst primary care physicians and GPs, there's a huge degree of difference in terms of experience and comfort in terms of managing melanoma patients. And we certainly have people who range from not managing much skin oncology through to running very busy skin cancer practices. So I'll try and encompass something for all, but please ask questions if you arise, as Matt suggested. So the biopsy, in theory, the biopsy is a very straightforward part, and yet it's a part that can very often become tricky or challenging and can even jeopardize later treatment if in certain circumstances. So in order to understand why the recommendations for the biopsy are as they are, we've got to sort of think about what are the first principles of what we're trying to achieve. As with any biopsy, the goal is to get an accurate diagnosis. And it's well known that pathology or histopathology of melanocytic lesions is actually really challenging, and even more challenging than most skin pathology. It can be really hard for pathologists to very accurately determine whether a melanocytic lesion is an irritated mole that's benign or in fact a subtle melanoma. It can be really challenging in specific circumstances of children and other cases where we see a lot of Spitz nevus, and I certainly have a big practice looking after those. And there are even other rarer entities that we come across, like melanocytomas and other tumors that are based on melanocytic lesions that can be very difficult to differentiate. So in order for the pathologist to have their best chance at making an accurate diagnosis, the way that the tissue is sampled at that first biopsy really is your best chance at ever achieving a diagnosis in some of these cases. And for that reason, the goal is to produce a complete specimen for assessment for the whole specimen, but also for the looking for other features such as the symmetry or the interaction between the lesion and the normal tissue at the edges. So we should all be familiar that the guidelines, and this hasn't changed, suggested a complete excision with a 2 millimeter margin. And here's a picture of a suspicious pigmented lesion with a patient who had a clinical history of a changing lesion or changing mole. And on this occasion, taking this off the upper arm is straightforward, and performing an excision biopsy is not of any challenge. There's an example of similar lesions where excision biopsy is achievable. But even here, we're starting to come into scenarios where there may be some challenge. So in the top left, a picture of the calf or lower limb, even though this is a lesion that can be excised, excising even that size from this area can be problematic with healing, and it may push the comfort of what people feel comfortable doing in an office setting, depending on what equipment they have available. These pictures of a gentleman's shoulder show what's becoming quite a large pigmented lesion. And again, even though excision biopsy is feasible, the excision's growing in size. There are occasions where the lesion might be small, but its anatomical location might mean that doing it in the office provides some challenges. So not many patients tolerate local to the sole of the foot, and some are particularly averse to having procedures done even for simple biopsies like this. There are going to be times, though, where a complete biopsy is not really feasible. And we acknowledge that, and everyone is aware that that is the case. But when faced with those scenarios, it's really important to have a good understanding of the pitfalls of partial sampling. For the first part, it risks getting a wrong diagnosis and producing a report where the pathologist is unsure whether the lesion is malignant or not malignant. And in cases of true melanomas, one of the things we worry about is, and we'll speak a lot about Breslow thickness, but the most important prognostic staging is actually the depth of invasion. And when you take a partial sample, even if you can make an accurate diagnosis, and even if you can measure a Breslow thickness, you're never sure that you've actually sampled the deepest portion of the lesion. And certainly you can undercall the true depth of invasion. Shave biopsies are themselves a very contentious part of this discussion. And in many settings and conferences, there are discussions about shaves, and we'll talk about those more in a moment. These are some images of times when a complete biopsy is just simply not feasible or remotely feasible. And in these cases, to achieve any kind of diagnosis, we accept the fact that we're going to be performing some sort of partial biopsy. The bottom right with subungual or nail bed lesions, biopsying these is itself a surgical procedure that has its own pitfalls and problems. So shave biopsy is an interesting case, and the debate rages on both in the literature and in conferences about its merit in melanocytic lesions. So there are certainly some features about it that that are real and that need to be sort of considered. The crux of it comes down to the fact that shave biopsy in skin cancer practice is absolutely a good technique. It's rapid. It allows patients to not have stitches and sometimes not need a follow-up appointment. With lots of lesions that need to be sampled, it certainly is a very pragmatic way of sampling cases, and is better than not probably biopsying many a lesion. But when it comes to lesions where there's a possibility that it's a melanoma or even a probability, there is some real dangers. And the danger is transection of the lesion. So shaving on too shallow a level and cutting through the melanoma in somewhere in its midpoint. And so we call that base transection, and it's a feature that has been studied a number of times, and there are huge variations in the estimates of how frequently base transection occurs. But as someone who works on the other side of that equation in tertiary referral melanoma centers, I see a lot of base transected lesions. And every time we do, it creates a lot of diagnostic dilemmas for us, because that information about the thickness of the tumor, once it's been shaved, is lost forever. As part of the healing from the shave biopsy, we know that there are melanoma cells destroyed, so you can't simply come back and excise the base and add two scores together. But we know that once we've lost that information, we've lost it forever. So it can make challenges for the initial consultation for deciding about whether or not the patient needs a sentinel node. But with the newest staging system, it also can have some downstream effects. And in the bottom right there is a table, and we'll come to this later in the talk, but this is the way we work out what stage 3 classification a patient has. And in the newer system, to work out the difference between, and stage 3 is a patient that has some degree of melanoma spread to their lymph nodes, to work out whether they're in the A category, which has a good survival and often doesn't need drug therapy, or the D category, which actually has quite a worrying survival curve and almost always go on to get some additional drug therapy. We're actually not just looking at how many lymph nodes are involved, but in the new system, the original thickness of the primary tumor is an important part of actually stratifying and classifying these patients. So it's quite interesting to, and unique to see that the way the initial biopsy was done can actually have quite reaching implications for, downstream decisions about drug therapy when the patient presents later with much more advanced disease. So as a good practice point, I would certainly advise caution with this technique. And I think we'll leave it there, but we might get some questions about that later. Once a biopsy has been performed, we get a pathology report, and a melanoma pathology report contains lots of very helpful information. This is the synoptic portion of a melanoma report, but a report really should contain 2 parts. It really should contain a written blurb that actually is more of a description of what the pathologist saw, combined with their sort of subjective opinion about what's going on. And then we always recommend also having a synoptic report where the key measurements are recorded like this. In this report, you'll see that the key portions are the Breslow thickness, the ulceration, the mitoses, microsatellites, and margins. And we're going to go through some of those features shortly. I've mentioned it a few times, and there's no limit to how many times it's worth mentioning. The Breslow thickness is the single most important prognostic factor when we're dealing with an isolator or primary tumor. And it's measured from the stratum granulosum, or the first cellular layer, down to the deepest melanoma cell. The Breslow thickness has been shown to be the most significant factor out of all the different things that we can measure. But also of importance are things such as ulceration, mitotic rate, the presence of TILs, which is actually a positive. Microsatellites is very important. We'll speak a bit about those. And then if they actually witness uncommon events such as lymphovascular invasion, which is a significant effect. Clark levels are reported, and Clark levels used to be part of our HACC staging system, but have been removed now because they're found to not be that reliable. A lot of concern, sometimes patients, I've met patients with a lot of concern about their Clark levels. There's a lot of confusion sometimes when patients go to Google online and start researching their own reports. Because the Clark levels are represented in Roman numerals, I've met many patients that have actually Googled stage 3 melanoma or stage 4 melanoma, which is quite disseminated and advanced melanoma, when what they actually had was a very early melanoma that was Clark 3 or 4. I've even had occasions where health insurance companies have refused to offer people life insurance because of their Clark 4, but 0.2 millimeter very early melanoma, because they thought the patient actually had quite advanced melanoma. So it's interesting to see the confusion that it causes, but the relevance of Clark levels is pretty limited. It's been shown to not be as reproducible. It's actually a bit of a subjective call. It's looking at the same metric as Breslow thickness, but instead of measuring it just in millimeters, it's looking at which layer in the skin is occurring. Level 1 is epidermal only, so that's melanoma in situ, and 2, 3, 4, and 5 extend all the way down to the subcutaneous tissues. But for the most part, it now no longer forms part of our major predictors. And so we can really move away from looking at it as much as we look at Breslow thickness. Coming back to the Breslow thickness again, it is the main way that we break up our primary tumors into T1, 2, 3, and 4. Essentially, this is the most up-to-date 8th edition, and it's changed a little bit from the 7th, but T1s are now anything less than a millimeter, and if they're up to 0.8 with no feature, that's an A, T1A, and if it's 0.8 with ulceration, or if it's 0.8 to 1 without ulceration, that's a T1B, and then moving up that system. And for me as a surgeon, seeing patients referred with melanomas, and a lot of discussions being around sentinel nodes, people often look at this T category as being very close to where the recommendations are for who should and shouldn't be considered for a sentinel node. Although, again, we'll speak about that more later, because even that is a changing landscape. But certainly, your T staging after you see a patient with a primary melanoma, and this is often recorded in that Synoptic report, is one of the most important features of that report in terms of having a sense of their risk of recurrence, their risk of metastasis, and ultimately their risk of dying from the melanoma. This is just covering those features. So moving away from biopsy, I guess if there are any questions about biopsy, now might be a good time to take them.
Yeah, can you hear me, Michael?
Yeah.
Yeah, good. I've not seen any questions yet.
Right.
Maybe Lydia, I just double check. I think I'm looking at the right section here.
No, there are no questions so far, but I've reminded everyone to submit the questions to the Q&A box, please.
Yep, all good.
That's good. Everyone must be very happy with biopsy, and no one found my caution about shave concerning. That's good. All right, let's move on. So once I guess the final thing, I guess, to say then, if there are no questions, is with biopsy, you know, it is different to other skin cancers. In many other skin cancers, any biopsy is a good biopsy, and there aren't many pitfalls. Here, there are those special cases where you can potentially actually cause harm through biopsy, you know, with shaving if you transect a base, or, you know, even cause confusion if there's something partially sampled, and then by the time you come back to try and resample the lesion, there's the additional problems of having healing and inflammation. So the pathologists get more and more confused about what we're dealing with. So it is an occasion where I would absolutely encourage people, if they're not very comfortable with biopsy, not to be afraid to pick up the phone and actually call the person that they normally refer their melanomas to and have a chat to them if they've got questions or concerns, and not be afraid to, if they're worried about a large lesion, refer. In general, a punch biopsy is a reasonable approach, although it has limits, and we all employ it, and I don't think you should be concerned about doing that if it's a large lesion and you want to take a sample. And in those cases, you know, you look at the worst clinical portion to aim your biopsy, and just wherever possible, be performing excision biopsies with narrow margins. We'll come to it again when we talk about sentinel node, but it's very important to not take more than a 2 millimeter margin when you're doing the biopsy, to not perform a flap or a graft or another complex technique, because should that melanoma come back as one that would benefit from a sentinel node, those larger excisions or more complex techniques of reconstruction will change the lymphatic drainage and mean that that patient can never receive a sentinel node biopsy. So when considering a lesion that may be a melanoma, and that's on your differential diagnoses, the narrow excision margin and a simple primary closure is quite important. So let's move on to actually performing wide local excisions and what's happening in that space. So our wide local excisions are based on our guidelines, which are all found on the wiki, and we'll look at what they currently say. There's only been a subtle change to those with the latest update. That we acknowledge, though, in the guidelines that there are anatomical constraints. You know, achieving a 2 centimeter margin on the face, on the nose, is not feasible. It's not practical. There are times when lesions are excised with narrow margins to save vital or important functional structures. There are other subtype variants, and I think it's beyond the scope of this talk to look at all the subtle subtypes of melanomas, but certainly desmoplastic melanomas and other types of melanomas that are rarer that occur where margins and attempting to get local control might cause you to do something different. And again, lentigo maligna, will cover melanoma in situ lentigo maligna in a little bit, is a special case where margins are very interesting, and those lesions are often quite problematic with getting adequate margins. And the final point is one which is everyone should be familiar with and be reminded of, is that when we're performing a wide excision, once we've got a diagnosis of melanoma, it is not just a skin excision. It is not the same as when we excise BCCs, SCCs, and other skin cancers. So what are the excision margins in the current guidelines? And here we have them. So for melanoma in situ, for melanoma that is limited to the epidermis, the current guidelines actually now offer a range. And this is a change. The previous guidelines had said the margin that was recommended was 5 millimeters. We've now moved to a 5 to 10 millimeter recommendation. And the current guidelines actually acknowledge the difference between melanoma in situ and lentigo maligna here, which is an interesting differentiation. So really, there are 3 names that are often used, and sometimes and historically they've been used interchangeably: melanoma in situ, lentigo maligna, and Hutchinson's melanotic freckle, the eponymous name, were often used to describe any melanoma that was limited only to the epidermis, which is a Clark level 1. But in the newer guidelines, we're starting to tease out that there actually should be a difference between melanoma in situ and lentigo maligna, with lentigo malignas being more common in sun-damaged skin, often in the elderly, often in the head and neck region. And there's a histological feature that goes with a melanoma in situ that qualifies it as a Lymphedema maligna, and that is the presence of solar elastosis, which is a histological sign of severe sun damage. And when we've given this range now for this early disease, it's really to take into account that Lymphedema malignas, these in situ diseases occurring on sun damaged areas, usually of elderly patients, actually are associated with a high local recurrence or rate, or field defect that we sometimes see where people have multiple lesions. And for that reason, the guidelines offer this range where they actually acknowledge it's reasonable sometimes to take even a centimetre around these. For the T1 lesions, it has remained at 1 centimetre. For the T2 and 3 lesions, there again is a range between 1 and 2 centimetres. We'll cover that in a second. And for the lesions over 4 millimetres thick, the recommendation is 4 millimetres. This is covering the point of a few things here. And what we should say is, firstly, these recommendations are all recommendations for clinical margins. That means that this is the margin that you, as the person excising the area, draws on the patient's skin with a ruler and what you set out to cut out. It is not a histological margin. There are no guidelines that exist that actually tell you what margin you should accept when you get the pathology report back. And so certainly, you know, there is sometimes confusion where people receive back a pathology report that has a margin of 8 millimetres when it was their intention to take 10, and they might be concerned that they haven't actually followed guidelines. Well, if they drew a centimetre around the lesion and excised it with a clinical 1 centimetre margin, then you have followed the guidelines. What this picture is depicting is the lower leg of a young patient, a healthy young patient with good quality skin, with thick dermis, with lots of elastic fibres. And this is a melanoma, and it's been excised with a 1 centimetre margin. And when that piece of tissue was on this person's leg, that measured exactly 1 centimetre. And as soon as I've cut that out, two things have happened. One, the specimen has shrunk up because those elastic fibres have done exactly what healthy young skin does and recoiled. And two, the defect has sprung open and looks ginormous. And so this is displaying initially something that is harder, especially sometimes for patients to appreciate, which is that there is a huge amount of elastic recoil. So I know from the start that when I send this specimen off, I am not going to get a histological margin of 1 centimetre, and yet I am certain I took a margin of 1 centimetre. So it's a good display for people to show them that there certainly is shrinkage. There's further shrinkage when you put this specimen in formalin, because formalin dehydrates it and causes additional shrinkage. And the problem is there's no simple calculation that you can do to relate a clinical margin to a histological margin. Some people allow for 20 or 30%, but it's highly variable. There's a big difference between how much skin recoils on an 18-year-old's leg in this picture and on a 90-year-old's cheek, where not much occurs. There are differences in gender. There are differences that are racial in origin in terms of how much elastic fibers are present, how much recoil we see, and there are just differences in different individuals. So there's no set formula you can use to be sure. So it's important to remember those clinical margins. It's important to perform the clinical margins, but if you know you've performed the adequate clinical margin, the histological margin, it can't be ignored, but you take it in consideration of that. There are certainly times when the histological margin isn't adequate, but there's no hard and fast rules. It's certainly a individualized sort of decision with each individual patient as to whether you're going to accept that margin that comes back or not. And it relates to a few factors. The other thing this photo shows is what a wide local excision should look like in terms of being to the level of deep fascia. And this is that point about this isn't just a skin excision. This is an excision to the layer of deep fascia. And it requires closure, usually with some techniques that include deep sutures to put those deeper layers of tissue together. Being at this level on the body actually will put in jeopardy a number of additional nerves, usually cutaneous nerves, that you wouldn't normally need to think about if you were just doing skin excisions. And again, for that reason, it's important that if you're going to undertake wide local excisions, and lots of wide local excisions in Australia are performed in primary care settings, and that's completely appropriate in certain circumstances, you really need to actually have the experience and training to know about how to repair these defects properly, how to do them, and have a sense of where those other cutaneous nerves lie, because you know, in many cases they don't need to be injured, they just need to be identified and preserved. So yeah, moving on. Lymphedema maligna. Lymphedema maligna is an interesting and challenge in and of its own right. Lymphedema maligna is often a large lesion that occurs in the head and neck area and requires some form of reconstruction. And certainly they come often very close to important structures like eyelids and noses and other areas. And for a lesion itself that is essentially pre-malignant, treating them with wide surgical excision can have a lot of morbidity. So it's quite challenging, not because it's the most dangerous or life-threatening melanoma, but quite the opposite, because we treat them due to their risk of eventually becoming invasive disease, and yet treating them surgically can often be more morbid than many of the actual more invasive melanomas that we treat. This is looking at a trial of histological margins and macroscopic margins, I should say, and how often they were actually cleared with lentigo malignas. And one of the problems for lentigo malignas clinically is that when we see these patients, these elderly patients with sun-damaged skin, looking at these large lesions, it can be very difficult to determine where they stop and start. They often fade at the edge into just other background of sun-damaged skin. And actually what's interesting is the pathologists under the histology often see the same thing. So under the microscope, they see the abnormal cells, and instead of seeing a defined edge, again, they generally fade out until we're just seeing little individual atypical pigment cells. So having a sense that you've cleared it all can be really challenging, and measuring margins isn't necessarily straightforward even for the pathologist to measure a histological margin, because where one pathologist calls the edge of it might not be the same as the next. When we see reports about this, they often talk about confluent and then single atypical cells. And certainly a good report would mention both. And for the most part, a confluent edge is what we're looking for clearance from. I often again get asked what sort of histological margin I accept on a lentigo maligna. And again, there's no single answer. It really depends. It depends on the patient. It depends on the type of reconstruction that would be needed if you had to go back and take more, or what the morbidity of operating on them again might be. It depends on the level of concern from the patient, and it's often a bit of a discussion with the patient as to whether you're going to follow these patients up closely with less than ideal margin or subject them to further surgery. Ideally, we said we want histologically 5 millimeters, and for me 3 millimeters is a good number that I often base my decisions off, but there's no one hard and fast rule. And I've certainly re-excised melanoma in situ that had a histological clearance of 3 millimeters where it was appropriate to do so and the morbidity was reasonable, but there are also occasions where you might choose not to. So it's not straightforward. There are other things that can help us in managing lentigo maligna. One is confocal microscopy. That's a very specialist dermatology technique that uses essentially a laser microscope. And it's a technique that involves being able to actually look at a large area of the patient's skin without having to actually perform a formal biopsy. The disadvantage of confocal, you can only really see the very top layers or epidermis of skin. So it lends itself to lentigo maligna, but it's not particularly helpful in other more invasive disease. And one of the challenges of confocal is really just that it's a very user dependent modality, and it requires a bit of subjectivity. We use confocal, and I certainly use my practice. I use it in a number of circumstances. Sometimes when I really can't tell where lentigo maligna stops and starts, I might get the lesion mapped and the edges drawn with the best guess that we can get, which involves some confocal, and then base my surgery on that. We use it for following up cases. So if there have been lentigo malignas that had elements of them that actually had no pigment at all, and that's a terrifying thing that we have to look after sometimes, patients who have repeated positive margins even though there's no longer any sign of a brown lesion. So confocal can be helpful when you just simply can't see it. And it can just be used to follow up some high-risk patients. So, there are patients who, even when you get a clear margin, they still have on the pathology atypical pigment cells scattered throughout. And your sense is that even though you've cleared this lentigo maligna, there's essentially a field of atypical pigment cells waiting to spring up another one. So their risk of further lesions in that area are really high. So those patients might go for 6-monthly confocal as a way for monitoring the area and guiding any biopsies that need to be done. We talked about the margins, and certainly the fact that there's still some uncertainty in the guidelines, particularly for those cases where we're dealing with melanomas in the intermediate thickness between 1 and 4 millimeters. The guidelines recommend between 1 to 2 centimeters. One of the reasons for the fact that there's in fact a range offered is because we've never had a randomized prospective trial of 1 versus 2 centimeters for these patients. So those recommendations that we have for the margins are based on some very large international trials that are summarized in this table. And you can see the margins they're comparing in that middle column. We looked at 1 versus 3, 2 to 5, 2 to 5, 2 to 4, and again 1 to 3. But we've never had a 1 versus 2 head-to-head trial. So, you know, even though something as simple in melanoma management, something that is such a daily occurrence for all of us in terms of excising intermediate thickness melanomas, we still have unanswered questions about what is the ideal margin. And we're actually going back, and there's a trial running at the moment through Melanoma Institute and multi-center around the world that's actually finally comparing 1 to 2 that's in an accrual phase at the moment. So hopefully we'll have more clarity about whether a 2 centimeter margin is even needed for those patients. At the moment, most of us are guided by other features in that tumor. Certainly if there are other high-risk features, we might push for a higher margin. And again, that same relationship between, well, what is the morbidity of taking that bigger margin? Does it mean a skin graft instead of being able to suture it together? Does it mean sacrificing other important structures to achieve it? So it's a very subjective decision at the moment, but in the future, we might actually have more clarity. And this is more about that trial, which is underway. So that's excision of the primary lesion. For me, the most of them, I tend to actually perform that as a procedure in a day surgery under some sedation when I do my wide local excisions, which is not mandatory, but the excisions to deep fascia can be quite uncomfortable. And most patients seem to really benefit from having some sedation on board. But it doesn't need to be so. Many wide local excisions are performed in an office setting or in a room setting with appropriate local anesthetic. We'll cover the sentinel node biopsy because that'll really delineate which patients really should be referred on and which are more appropriate to have a wide local done in a primary care setting. But does anyone have any questions about wide local excision?
No, there's no questions yet.
Right.
I think, like you just said, I think, and what I'm thinking, what you're about to answer is, yeah, which ones are appropriate for us in general practice.
Yeah.
Like you said, it's going to depend on this sentinel node biopsy question.
I think that's the crux of it. I mean, obviously the answer to that question is very variable as to people's level of experience. You know, certainly sentinel node biopsy means that you need to be doing an operation in an operating room. People need a general anesthetic for a sentinel node. So people who go on to have sentinel node or a discussion about it clearly need referral. There are people, I guess, who come along with earlier melanomas because they have high levels of anxiety and they want to come and see someone as a specialist who looks after it. It's interesting that working over at the Melanoma Institute, I have people that, even though they're referred to my COGA rooms, actually want to come to the Institute, healthy young people, even with early disease, just because there's sort of a psychological benefit through walking through a door that says Melanoma Institute. So I guess levels of patient anxiety is a reason to refer as well. And then, you know, those challenging anatomical locations. But there are many melanomas that occur. And melanomas are more common as we get older. There are lots of elderly patients, and you know, there are many that are very amenable to an appropriate wide local excision, you know, outside of an operating room and outside of specialist care. So we'll get on to the bit that often causes a lot of confusion, and it's understandable because that it causes confusion. It's a confusing conversation to have often with patients, and that's what is the role of sentinel node biopsy. How are we going for time, by the way? Sorry, my clock disappeared.
8:10.
Ah, perfect.
So
All right.
40 minutes or so. Yeah.
Perfect. Then we will spend it talking about the bit that we all want to talk about, which is sentinel node biopsy. What is it, who we should do it on, and what's it all about? Because even this is something that, in my melanoma career, has changed dramatically. So before we can talk about who should have one and what it means, we better talk about what is it and what does it look like. Sentinel node biopsy is a surgical technique. It's a combined technique. It involves nuclear medicine, it involves surgery, and it involves a pathologist. So there are 3 core parts to it. And the whole process really, and as I explained to patients, in 2021, functions mostly as a test. It's a prognostic series of procedures for the most part. And we can touch on some of the contention around whether itself, sentinel node biopsy itself has a survival benefit, but let's talk about it as it's used today mostly, which is as a prognostic exercise. So that itself is a concept that for a lot of patients it's hard to necessarily take on board initially, that we're talking about doing a surgery that may itself not have a benefit other than finding out some more information. The concept of a sentinel lymph node is any lymph node that receives direct drainage from a spot on the skin. So as I explained to patients, the lymphatics are our tissue fluid pipes. Those lymphatics have little filtering stations that we call the nodes or glands that are in little groups under the arms, in the neck, in other sites. And for any given point on your skin, you'll have a set number of pipes that drain to one of those areas. And before those lymph nodes are plugged into all the other lymph nodes in that network, they'll travel to 1, 2, 3, or 4 lymph nodes first. And any of those first lymph nodes are the sentinel nodes. So for any given location, and in this picture here, we have a patient who's got a purple mark outlining their melanoma on their shoulder. We don't know where their sentinel nodes might lie. For this patient, those lymph nodes, that site on his skin might drain into pipes that go into the armpit. They might drain into pipes that go to the base of the neck. It could be both. There might be more than one pipe. And at the end of each of those channels, they might all meet on a single lymph node, or they might travel to different. So there's a huge variation over your body in terms of where the lymph drains to. There's a huge variation between individuals, and there's even variations between left side and right side. And it's for those reasons that it's really important that we haven't performed wide excisions initially on the biopsy or done a flap or a graft, because the first step of this process is to get a map made. And the way a map is made is that the day of surgery or the night before, the patient is sent to a nuclear medicine laboratory. And at that laboratory, an injection of a radioisotope is made directly into the site where the melanoma was. And so the problem with the bigger excisions or with other types of procedures that have changed the lymphatic drainage is exactly that. You're no longer injecting where the melanoma was, you're injecting now 2 centimeters away from where it was, or you're injecting into some skin that's been moved in a flap differently or a graft. And for that reason, even though in those cases you'll get a map, you may no longer be accurate. It might now be showing you where a different piece of skin drains to, because for any spot on the body, there will be a different area. And how big the domain of any one sentinel node is in terms of how far do you have to inject away before the map starts changing is variable over the body. So it can be quite subtle, especially in the head and neck, or it can be quite large areas that are covered by a single node in other sites. So in this picture, they've injected the radioisotope in the top left, which is a sulfur-antimony colloid. And here on the bottom right is one of the first real low-res images that you'll get back from the gamma camera in the nuclear med scan. But this one depicts quite nicely a big blob of black, which is where they injected the area, and a single hotspot in the axilla. So this is a very simple lymph node map that this patient's setting up for. We got a whole series of additional images that look and can actually see with clarity how many pipes there might be. And it's possible that you might have really complex drainage patterns with lots of pipes going to multiple nodal basins with multiple nodes in each, or quite a simple drainage pattern. This drainage pattern has nothing to do with the risk of the melanoma at all. This is just a map of where the lymph flows for this patient's skin in that location. So the next bit is to try and start to localize and get some anatomical information about where is that hotspot, where is that lymph node located. So we often perform a SPECT CT, which is a low dose radiation CT combined with a gamma camera to try and start to localize anatomically where this is. And then they're able to mark an X on the skin as an estimate of where that lymph node will be. Central lymph node biopsy maps or lymphoscintigrams for melanoma can in themselves be quite a specialist skill. So sentinel lymph node biopsy is a technique that's used across a number of cancers, but the way it's carried out and used for different tumor sites like breast cancer, the significance of it, the way the techniques are done, they're all subtly different. And so for melanoma and for mapping skin, there are certainly some techniques that are important and different to those other areas. But for melanoma, this is what happens next. We then, that same day, while the radioisotope is still in the patient, take the patient to the operating room. And if we're going to do a sentinel node biopsy over there where the X marks the spot, we mark an incision site. And we often add in some additional blue dye. The blue dye is just a blue ink that travels in the lymphatics, and it means that the lymph nodes will actually tend to concentrate that and show up blue when we make a cut in the armpit. Lymph nodes otherwise just look like little blobs of fat, and without the blue dye, they can be hard to make out at times. So the blue dye is a visual aid. So during the surgery, and for all those reasons that we talked about, or that I mentioned about not doing the wide local excision first, and not doing flaps and grafts before doing this, it's for that reason that the wide local excision and the sentinel lymph node biopsy have to happen at the same time. So these patients are booked for the two procedures to occur simultaneously, with the lymph node map in the morning, procedure in the afternoon, or some variation like that. So the first step we do is after we've injected the blue dye, we then make a cut over where our marker is, or in this place, the armpit. We use a gamma probe, which is basically like a Geiger counter, and that radioactivity that gave us the nice pictures for the map is still in that lymph node, and we can work out where that lymph node is, and it gives us a direction. And so amongst the 20 to 30 lymph nodes in the person's axilla, we can identify the one we're interested in. And there it is, nice and blue, because we've put the blue dye in, and it's got a nice high count on that gamma probe. So we take that lymph node out and we send it away to the laboratory for histopathology. So at the time of surgery, we have no additional information. And this is, again, different to breast surgery, where there are some techniques in breast surgery where they can get some flow cytometry and early answers as to what's going on. But here, we actually rely on histopathology. So at the end of the procedure, we're none the wiser as to whether there's melanoma in that lymph node or not. Taking that single lymph node out has some risks, and sentinel node biopsy is a surgical procedure that, like all surgical procedures, has morbidity. It produces a scar, there's risk of infection, bleeding, wound problems, although they're quite rare. There's risks of having some numbness related to the scar, which again is quite rare. The bigger risk that we often worry about is disruption of the lymphatics. We've all had patients who have had lymph node dissections where all their lymph nodes are taken out, and in breast cancer often with the addition of some radiation, and the lymphedema is a real problem and a real concern. In sentinel node case series, the rates of lymphedema have been quite low, but they're variable by site. So lymphedema rates in the lower limb, so when we take out sentinel nodes, so 1, 2, 3, or a small number of lymph nodes from the groin area, we see rates that are often around 1%, although sometimes higher, of lymphedema in the lower limb. When we do that same procedure in the armpit for the upper limb, the rates are more like 1 in 1,000 of lymphedema after a sentinel node biopsy. And in the head and neck region where we do it, they're essentially form case reports, because they're that rare when we see patients who have had lymphedema following a sentinel node biopsy. So the morbidity of the procedure of a sentinel node biopsy is quite variable depending on anatomically where that lymph node drains to, where that map shows us. And it's not simply a black and white, these are the risks of this surgery. And in many ways, what can be challenging is you don't know a lot of factors until you get the map made on the day of the operation. So you don't know exactly where the lymph nodes will be. So if the melanoma was in the middle of the back, is it going to go to their groin? Is it going to go to their armpit? If it's smack bang in the middle of their back, could it drain to all 4 sites? Absolutely, we've seen that. And you don't know how many lymph nodes you're going to have to harvest or how many different additional surgical sites. So all of those factors make it quite an involved conversation, and we'll come to that conversation a little bit. And for those reasons, that's why the way the guidelines reflect sentinel node and where some of this confusion starts to come in. So what is the current standpoint of sentinel node biopsy in 2020? Well, no one debates, and there's really never been a debate, that it's an excellent prognostic test. Of all the things that we can measure about a melanoma, Breslow thickness and everything, this is the one that has the odds ratio that tells us the most about patients' risk of survival when dealing with localized melanoma. In the newest edition of AJCC, 8th edition, sentinel node is required in order to actually stage people properly. So you can't officially give them a staging category if they haven't had one. But I like this sort of line, which is really stating where we're at right now. The sequence here is that in 2020, when a patient has a sentinel lymph node biopsy procedure, and if that lymph node comes back as positive, we refer those patients to a medical oncologist, and that medical oncologist considers giving them drug therapy. Prior to 2018, when patients had positive sentinel nodes, they went on for more surgery, and we would go back as a separate procedure and do a formal lymph node dissection. And that meant clearing out the remainder of all their lymph nodes, But in 2018, the results of a very large randomized controlled trial, the Mslt2 trial, was released. And that trial showed that even though taking the rest of the lymph nodes offered some advantages, it gave more information because you could count how many other lymph nodes were involved. So it was additional prognostic information. It gave you more disease control regionally. So the patients that had those dissections were less likely to end up with recurrences in their armpits and groins that were causing problems, but it did not improve survival. And so when that came out in 2018 or just before, there was a global shift in what we did with patients who had positive sentinel nodes. And serendipitously around the same time was when the results from our adjuvant drug treatment trials came out that showed that there was in fact a survival benefit for patients who had sentinel lymph nodes that were positive, but no other disease if we gave them drug therapies. And so right now in 2020, the reason to do a sentinel lymph node biopsy, the importance of sentinel lymph node biopsy, is that it is the gateway by which patients can get life-saving drug treatment. So here's the question, who should be getting a sentinel lymph node biopsy? The answer to that question, again, is not necessarily black and white, and it comes down to a discussion. And that discussion really centers around one key metric, and that is, what is the actual chance that that melanoma patient has occult lymph node disease? So what is the chance that even though you've examined their lymph nodes and they're clear, and even though you could subject them to any form of ultrasounds and other scans, but what is the risk that they actually still have micrometastatic disease that you're only going to find if you do a sentinel node procedure and take out the key lymph node and send it for histology? And so that is actually the most important thing that we would want to know. And any kind of guideline is actually using some sort of surrogate or proxy to try and estimate what that risk is. So the way this is reflected in our current guidelines and what they state is that sentinel node biopsy should be considered for all patients with melanoma that is greater than 1, or for patients with melanoma greater than 0.75 with other high-risk pathological features. Now, this statement on its own seems pretty simple, and yet it's really not. This guideline does not say that we should do a sentinel node biopsy. It says it needs to be considered. And many of those elements that we were talking about before about not all sentinel node biopsies being created equal is part of the reason why the guideline can't say you should do it, because the individual morbidity of a sentinel node procedure can vary greatly, even for one individual, based on the map that you only find out on the day of the procedure. There are other problems with sentinel node biopsy. It requires a GA, so you're turning a wide local excision that could essentially be done at the local into a procedure that requires a general anesthetic. So that alone, might be contraindicated in some patients. And ultimately, if sentinel node biopsy is the gateway to drug treatment, for patients that might have a contraindication to drug treatment, or for patients in whom they wouldn't want drug treatment for other reasons, then the value of a sentinel node biopsy is certainly less. It's only prognostic, So the guidelines reflect all that by instead of saying you should do one, you should consider it. The next part of that statement that's a little bit interesting is greater than 1 millimeter, they've said, but greater than 0.75 with other high-risk pathological features. But they don't stipulate which are the high-risk pathological features. We all would agree that ulceration certainly is. Most of my colleagues would argue that a mitotic rate, a TMR, so how many mitoses that are seen, if that was elevated, that should be. But is Clark level 4 a high-risk feature versus Clark level 3? It's not clear. And certainly, those Clark levels that we said have their own problems with interpretation and subjectivity. So, it is a statement that's a little bit intentionally vague in some ways. So again, it's hard to be prescriptive when the guidelines themselves have uncertainty built into them. So where are we at, and what makes up actually that conversation about having a sentinel node biopsy? Well, for me, it starts with exactly that, a conversation. So patients that are referred to me with a melanoma approaching a range that meets the guidelines and also using some other tools, we have a conversation about sentinel node biopsy. We go through carefully, and I explain to them exactly what we've talked about today, what it is and why we do it, and the importance of being able to access drug therapy that actually has been shown to affect survival in the occasion that someone has positive disease. And then there are some other aids that we can add to that conversation. And one of the things that has been really helpful for that conversation are tools like this. So this is a risk calculator that's on the internet. It's accessible to anyone, including patients and clinicians. And this one's published by Melanoma Institute. It's not the first, there have been others. Memorial Sloan Kettering published one many years ago that has existed for a long time and still accessible. But this one is a calculator that looks at more than just thickness. So instead of just using one metric or one surrogate like the guidelines do to predict what's the actual chance of a positive node, here we can be a little bit more nuanced and actually add in other features. And so it's important to understand this is only a tool that's an estimate. It forms part of a conversation with the patient. It doesn't replace the national guideline, and it itself has its own problems. But I find it a helpful way, and a lot of my colleagues that treat a lot of melanoma surgically certainly do, in terms of being able to talk about and put some actual real numbers on these discussions about should a patient have a sentinel node or not. So the idea here is that it's an individualized risk assessment, and it's about having more informed discussions. But yeah, it's certainly not simply a replacement for the guidelines, and that's really important. So what does it actually look like? When you log into these calculators, and this is the MIA one, they pick out a number of key features. So in order to create a calculator like this, it's a pretty involved statistical process, but a large database of melanoma patients are looked at, and univariate and multivariate analysis is done to find which are the actual features in that pathology report that gave the best indication in that patient group of what the chance of having a positive node was. So I mentioned that there are other calculators out there, and the Memorial Sloan Kettering one, the MSK one, has quite different variables that it looks at, including what part of the body and even Clark level. But the MIA ones picked out these variables as the thing that seemed to be important. So one of the key ones is age, Breslow thickness, of course, and then which type of melanoma, so superficial spreading or nodular or desmoplastic, which is quite interesting because for the most part, we often have thought about those types of melanoma as very similar in terms of matched thickness for thickness in terms of their risks of metastasis, but here there was actually some difference. The mitotic rate, so how many mitoses, ulceration, and of course, if present, lymphovascular invasion. And this is an example of what you can do with a calculator. So you can put in a 50-year-old with a 1 millimeter thick melanoma, the most common subtype, superficial spreading, 1 mitoses, no ulceration, no lymphovascular invasion. This is a pretty common melanoma in a pretty common age patient. And what we get here as an output is that there is an 11% risk, according to the calculator, of having a positive sentinel node. It's really, really important to look at that confidence interval underneath it when you're using this tool. And it's a little bit deceptive because the 11% is in a lovely big yellow circle and the confidence interval is just underneath in small writing. But the idea here is that the 95% confidence interval for this calculation for this patient tells us that the actual chance of having a positive sentinel node lies probably somewhere between 7 to 15%, which is a pretty tight band and quite a helpful calculation. Because the database this is based on has all sorts of different numbers of patients for each of these calculations, the confidence intervals can be very different between different calculations you do. So we wouldn't have necessarily that much data on 99-year-olds with 0.2 millimeter melanomas because our database that this was based on does not have lots of 99-year-olds who went on to have sentinel node biopsy for a 0.2 millimeter melanoma. And that might produce a very wide confidence interval that's a very unreliable estimate. And there are other measurements like this one that are quite reliable. So the confidence interval needs to be looked at when we enter in these numbers and considered, because again, this is all an exercise in statistics and an estimate tool. But what do we do with 11%? Well, the recommendation is actually written down at the bottom right. If you're getting above 10% chance of having a positive sentinel node, in general, they're the patients that benefit the most from having a melanoma sentinel node biopsy. So they're the patients in whom the risk of actually having disease is significant, and therefore the morbidity of all that extra procedure and surgery starts to be a really good risk-reward relationship. The calculator down there also says that between 5 and 10%, it's pretty reasonable to consider doing a sentinel node biopsy. And often for those patients, it'll come down to their other comorbidities, age, it'll come down to how complex that sentinel node procedure might be. So how many lymph nodes would need to be taken out. And so that's why this really is a helpful discussion tool. Going on, it's interesting that this calculator actually teases out some differences that are missing, because certainly if we go back for a second, a 50-year-old with 1 millimeter melanoma, well, the calculator hasn't really helped us very much, because if we just followed our guidelines, we would have said, yeah, this is a patient that should be referred for a consideration of sentinel node biopsy. But what's interesting is when we start moving these variables around in this calculator, we can see quite a broad spread, and effects of age are really interesting, because there's certainly one factor that has a big impact on the risk of a positive sentinel node. So if we put in a 30-year-old with a 0.6 millimeter melanoma with the same features, superficial spreading, 1 mitoses, no, we start to produce a 15% risk. So simply by having a younger age, even though they've got a much thinner primary melanoma, their risk of a sentinel node, according to this tool, is actually higher. And this is where it starts to get really interesting, because a 0.6 millimeter melanoma, even with 1 mitoses, does not fit into the guidelines of who should have a sentinel node biopsy. It is less than the 0.75. And so traditionally, if we were just following guidelines, we wouldn't have even spoken to a patient like this about it. And at the other end of the spectrum, if we put an 80-year-old in with a 2 millimeter primary, which would otherwise be thought to be quite a high risk primary, their risk is even lower than the 30-year-old. So age can have a big impact. What happens when we actually get a positive sentinel node, and just to touch on this again, is we start to be able to stage the patients properly. So this is that 8th edition, and this is looking at the end stages. And what that means is that for a sentinel node patient, we're looking at the A stages. So the way that the N category is done, or the lymph node category in a T and M classification for this, is N0 is pretty straightforward. They don't have any metastasis. And that means essentially in 8th edition, because you have to have a sentinel node to get an N category, that means they've had a negative sentinel node. N1A means a positive sentinel node in 1 lymph node. N2A is a positive sentinel node in 2 to 3, and N3A is a positive sentinel node in more than 4. And depending on your map, if you've only got 1 sentinel node anatomically, if that's what you have, well, even if it's positive, you're not going to be able to get N2A or 3A. So it's interesting to know that the anatomy actually can determine which way you're headed in terms of how many nodes involved. But certainly more nodes involved, sentinel or otherwise, is a worse feature. The B and C categories are when you have disease that is clinically detected. Someone comes in with a mass in their axilla, and certainly the C categories involve what we call microsatellites, satellites of metastasis. And I guess it's a reasonable time to mention this now, but it's almost a topic in its own right. In transits disease, satellite disease, meaning a melanoma nodule near the primary, and there's contention about how many centimeters away, because there's no real set guideline in our staging system, or even a tiny satellite that only the pathologist can see on the path report, a microsatellite. They're all essentially the same thing. So they are disease that has got away from the primary, is in the lymphatic system in the dermis, and is on its way to the lymph node basin, so traveling up your leg towards the groin or arm or wherever it might be. And it doesn't actually matter whether it's a big black lump that you can see, or a lump under the skin, or if it's close to the primary or not, or even if it's on the pathology report only and you couldn't see anything because it was microscopic. They all denote a melanoma that is actually stage 3. They all denote a melanoma that's starting to spread in the lymphatics, and it's all some form of C stage in N, because it is itself a poor prognostic factor. So going all the way back to that initial pathology report, looking out for microsatellites is really important, because a patient on the pathology report, it's about the only time you'll see on the initial excision biopsy that you can diagnose someone straight away with stage 3 disease. And those patients absolutely need referral, and they're all eligible for even drug therapy, even at that stage. So microsatellites, really important, and really important not to be missed, but it fits into the classification here. And that's just highlighting the differences. So once we've got our sentinel node done, we can work out what actual stage 3 they're in. And that's where this comes up again. And I showed you this earlier. So they've had their melanoma excised, they've had their lymph nodes tested, and now we can put those 2 bits of information together to work out properly which category of stage 3 disease they're in. So for example, if you had a let's call it a 1.2 millimeter non-ulcerated melanoma, which is a T2A. You had 1 positive sentinel lymph node, which is an N1A. We can use that table to follow along, and we will see That patient is in blue, stage 3A. And you can see that for that same patient, if their primary had been a little bit thicker and they had a T3 thickness, then all of a sudden they would have moved into the B category. So this is that idea that the latest classification system is to work out what stage 3 the patient is using that initial information about the Breslow thickness together with how many lymph nodes they've got involved to actually give you a category. And why does it matter? Well, it really matters here because of all the levels of melanoma or stages of melanoma. So stage 1 and 2 being localized disease, 3 being melanoma involving lymph nodes somehow, and 4 being melanoma that essentially is hematogenously spread and in solid organs. Of all of them, the group that actually has the widest ranges of survival is stage 3. There's a real spread in the difference between patients with 3A all the way through to D. And that's what this table on the right is. This is a survival curve with years on the bottom. And as we go along with years, we're seeing patients die, and that's why the curve is dipping down. This is the percentage of that are still alive. So 3A at the top has a lovely flat curve. And when we look at those measurements, their 5-year survival is 93%, which is excellent. And 3D, still lymph node disease, but more nodes involved and a bad primary with a thick ulcerated primary do very poorly, 32% 5-year survival. So having an accurate staging is really, really important in terms of being able to work out what people's survival is. And also for patients who, after they have their positive node and we've accurately staged them, as I said, it's the gateway to drug treatment. That means the next thing that occurs is they have a consultation with a medical oncologist. And that consultation itself is pretty involved, and the drug therapies are discussed and the risks and benefits are discussed. But this information and things like which of the 5-year survival curves applies to them is really important for patients in deciding about whether or not the risks of drug therapy are outweighed by the benefits for them. So those drug therapies that have become useful are here. So the Adjuvant systemic trials were published in the New England Journal of Medicine. And again, they came out around the same time that our results about doing further lymph node dissections for positive nodes came out. And it's been shown that both the targeted, so the BRAF type drugs and the immune therapies have both improved survival when given to patients in the adjuvant setting, including positive sentinel nodes. So right now, that's where the proven therapy for drug therapy tends to kick in. That's the earliest stage it kicks in at for patients with positive sentinel node disease, but no other melanoma in their body. So it's adjuvant, it's an additional treatment given to them. What's of interest still and under investigation is using the drugs earlier and earlier. And we have trials still underway that you're looking at giving the drug in a neoadjuvant setting. So that's for people who turn up with a big lymph node of disease in their armpit or groin or wherever. And instead of proceeding straight to surgery, giving the drug first, then performing surgery. And that's become the standard of care in sarcoma many years ago. And there are trials in melanoma for that. And there are trials also in looking at high-risk stage 2 patients. So that's patients who have had a sentinel lymph node biopsy that was negative, but had quite a advanced primary, thick primary, ulcerated primary, and giving those patients drug therapy. And those trials will be interesting to see the results and may again change how we do all of this and the impact and importance of sentinel node when those results come out. But for now, sentinel node is the way we get these patients onto adjuvant drug treatment, which has significant survival benefits. So, questions now.
We do have a few questions.
There we go. It was sentinel node that generated them. Good.
Yeah. So I'll just try and, there's a few, I'll just group them. Maybe first, with the sentinel node biopsies, in the case of, there's maybe a central back lesion and we do the scans and it goes to 4 different areas.
Yep.
Do you then take a node from each place, do you?
Yep. So the answer is that you can have any number of sentinel lymph nodes. It just means a first lymph node. So anytime when they do a map, they see a pipe, and at the end of that pipe, there's a lymph node. That lymph node is a sentinel node. And then they actually have clarity in those scans that they can then see, then it drains onto the next lymph node.
Yeah. So you might end up taking 4 sentinel nodes.
You could take 4, 5, 6 from all different sites. And the idea is that you can't just pick and choose which one suits you. So you can't just harvest one and produce a negative result and say, there you go, I took out 1 lymph node and that was clear, because the melanoma cell, if it metastasizes, has just as much risk of going down any one of those pipes to any one of those locations, and maybe only one of those 4 lymph nodes is involved. So to do a sentinel lymph node assessment, anything that they label as sentinel must come out. Partial sort of sentinel node biopsies it just doesn't make sense. You have no confidence in that negative result because you really don't know what's happening in those other lymph nodes. So that does create some interesting occasions, because there are certainly people that have those intermediate risks of positive nodes, that 5 to 10% range, and you might send them for a map, and you might even approach that by saying, well, if the map shows that taking out that lymph node is a low morbidity procedure, well, we should do it because the risk reward is reasonable. But if that map shows quite a complex location, or lots of lymph nodes and a lot of surgery, then perhaps you wouldn't do it. And in those circumstances, you might choose to mark the sentinel nodes and follow those patients up with regular ultrasounds. But you've got to be cautious with that, because following up marked sentinel nodes with ultrasounds is not a proven strategy. So, it forms part of that real discussion. And you can kind of predict, the sites that are going to have really challenging maps. Certainly head and neck sentinel node is itself its own specialty. Head and neck sentinel nodes often drain to multiple locations. Those lymph nodes are often located near really important neurovascular structures, the facial nerve, other important neurovascular structures. And the other thing is about it technically, you'll remember on that picture, there's a big blob of radioactivity where they do the injection, and then the lymph node's a bit far away, and we're using a gamma probe to try and find it. Well, in the head and neck, all your lymph nodes are stacked right on top of each other, right where the melanoma was. So trying to even identify them using a gamma probe when they've done an injection and the lymph node's right under the melanoma can be technically very difficult. And then there are other times when you get maps that are just not feasible. I've had maps from a back melanoma where the person had a lymph node that went off, a channel that went off to a lymph node in their armpit, and then a channel that went straight through their rib cage and went to a para-aortic lymph node. So you're faced with a person who's got maybe a 10% chance of having a melanoma metastasis, and you're going to offer them a procedure, a surgery that is just a test, it's a prognostic test, and you're not really about to do a thoracotomy to take out a para-aortic node for them. So, when you're faced with that, you actually would choose to scan all the lymph nodes. And again, it doesn't necessarily make sense to take out just an armpit lymph node, knowing you're leaving behind one that's really important that needs scans anyway. It's kind of the worst of both worlds. You've got some degree of surgical risk combined with ongoing need for scans. But it's clearly not a black and white straightforward thing, and it's sort of an ongoing discussion that doesn't really finish until you're holding the map immediately before the surgery.
What about, I feel like a lot of patients these days also get offered serial ultrasound as like an alternative to a sentinel node biopsy? Yeah,
it's a really good question. So the first thing you've got to be careful about is that serial ultrasound is not in our guidelines. Well, not clearly in our guidelines, and it's not being tested in a robust way like sentinel node has through major randomized international trials. There is the results of Mslt2, which compares serial ultrasound to completion dissection, is one thing, but serial noding sentinel nodes it hasn't been really studied to the same extent. Problem with ultrasound, and this is a real problem, is it's very user dependent. And it's really based on the experience of those ultrasonographers. I have lots of patients who have serial ultrasound of their marked sentinel lymph nodes for various reasons. They might be elderly and it offers some level of they've come and seen me, they've had a conversation about sentinel lymph node, and for various reasons, the surgery has not been in their best interest. The risk of it is too high. The GA is something they don't want. And in those cases, we might mark their lymph nodes and then do an ultrasound of them and follow them up with ultrasound. But having those patients, I always, where I can, send them to an ultrasound laboratory that just looks at lymph nodes, that has a lot of expertise. And when those patients go out into the community and just go to general radiology departments, the quality of reports you get back are really very varied. And in fact, the patients tell you that, you come in and sometimes you'll get a report of an ultrasound and it really doesn't fill with confidence that they had any confidence in what they were looking at. And you'll ask the patient, I'll say, just out of interest, how did you go with the ultrasound? Did you have a sense they knew what they're looking at? And they'll say, oh, no, they really didn't know what to do. They got 3 different sonographers in who all had a look and they really weren't sure. And you can kind of get that impression sometimes from the report. So, being an ultrasonographer, you need to be a master of, prenatal scans, antenatal scans, musculoskeletal. They're all individual specialties for a sonographer. And certainly looking at it with high resolution at lymph nodes is itself a very special skill. And I got to say also, there are times when the ultrasounds actually can be problematic. I had a patient that went for an ultrasound and just one-off went to one of the public hospitals because they no longer wanted to go to one of these labs that specialized in it for multiple social reasons, and came back out of the blue with a report that said they had every lymph node in their head and neck on both sides were all enlarged and definitely full of melanoma. And so now you're stuck in a situation where it seems really unlikely because their chance of having a positive lymph node, in the calculator was something like 8%, you're 2 years on and there's not been any signs of trouble, and you're thinking, how on earth did they go from 0 to 30 lymph nodes involved? And so now you're subjecting them to PET scans and other tests. So getting a low quality ultrasound or an ultrasound where the results are not so good is a bit of a worry. So it's not straightforward either. If I'm filling everyone with a sense that none of this is very black and white, I think that's reasonable. And that's probably true of all things in medicine. The more subspecialized anyone gets into any one area, the more nuance there is. The guidelines, are still the guidelines, and we can all take confidence that if you're following the guidelines, you're doing the right thing. And the guidelines don't have serial ultrasound as an alternative listed, and there's good reason for that, I guess.
Another question relates to briefly, is the site of the melanoma important prognostically? Is that a big factor to consider? Whereabouts?
Yeah, sure. It's a great question. It's really interesting. So prognostically, yes and no. Let's look at the prognostic, the way to answer that in terms of sentinel node. So the sentinel node calculator that I showed you, the Melanoma Institute one, does not include site on the body at all. And yet previous ones, such as the Memorial Sloan Kettering, the MSK one, did have that one as one of the variables that they were actually predicting sentinel node positivity from. So in other people's data sets, having a truncal melanoma compared to a limb, for instance, because it's pretty vague on their calculator, had a higher rate of sentinel node positivity, and that just wasn't borne out in this data set. So, it depends, I guess, on which database you're basing your calculations on, but there's a sense that, certainly, yeah, it can have an impact on the chance of a positive node, and there's been times that that's been shown. There are certainly importances in terms of morbidity, obviously, in treating different sites. That much is clear. Backs are straightforward, lower limbs and faces are their own challenges. And I guess the other site that's really important to point out is the aqua melanoma. So on the soles of the feet and the palms of the hand. Those are actually quite distinct subtypes, and even the fingernail ones are included with the acral ones in their acral lentiginous melanomas. They actually are quite different, and they've been shown to have quite different mutation burdens. The etiology is proposed to be different, so not necessarily just sun exposure, but other factors. And the way those melanomas they actually have a worse prognosis, often with a higher rate of sentinel node positivity, and they even have differences in the way those types of melanomas respond to the drug treatments down the line. So acral certainly a special type that has its own burdens, and equally mucosal or uveal. They're actually all sort of separate disease entities, which we're not going to talk about those two because they're their own specialties. But yes, so site is important. It's not in that calculator. It's been in others. Does it factor into my decision about sentinel node? Well, it does, because you look at the site and you think about where those lymph nodes are going to drain to. And certainly for those borderline cases, the 35-year-old lady with a 0.8 melanoma, I mean, and this is a patient I treat and see regularly. I talk to them, I show them the calculator, I show them the calculations. It says something like, 7 or 8% risk of a positive node. And I explain to them, if it's an arm or a high up on the back primary, that if it goes to their armpit, the risk of doing a sentinel node procedure is a 1 in 1,000 risk of permanent swelling, lymphedema. And most people say, well, that's not that bad. And they would tend to want to have their lymph node out. And then on the other hand, you have that primary on their leg or thigh, and you say, well, it's definitely going to drain to your groin. And the risk of lymphedema is, 1% or higher. And all of a sudden, the balance between a 8% risk or whatever it might be of a positive node versus a 1 to 2% risk of a permanent swollen leg isn't looking like such a good relationship for that person. And, people bring into it their own background. I've had young patients literally turn around and say, my mum had swollen legs and lymphedema. There's no way I'm going to have that. 1%, forget about it. So the site, gives you a real sense of what the risk profile of doing a sentinel node biopsy will be. You can't always predict where drainage will be to, particularly for the lower back or abdomen area, but you can get a sense, certainly if it's a leg or an arm, in terms of how much morbidity is going to be involved in taking those nodes out. And, even calculating lymphedema percentages is challenging because it comes down to how do you define lymphedema. So even the studies that looked at the rates of lymphedema, often they look at only patients that turn back up to a doctor's office and said, my leg's swollen. But if you start actually doing more sophisticated ways of measuring every person's had a procedure on their lymph nodes done. So if you do serial measurements, or you put their leg into a fluid-filled thing into a volume displacement, or even the electrochemical measurements for lymphedema, if you start actually measuring everyone who's had it, you might find that much higher than 1 to 2% actually have subtle changes in swelling after these procedures, even if they don't complain of it or symptomatic. So site is important for all those calculations and those discussions. And to really make that point again, like the Sentinel node consultation, it's a long consultation. There's a lot of information. Each patient actually that I see, I give them a handbook to take away. I encourage them to bring a family member, because there's a lot of information, and we go through a bit of a PowerPoint discussion about what it's all about, because it's actually quite a lot for someone to process, especially with dealing with the new diagnosis of a melanoma. And at the end of the day, I certainly see my job when it comes to Sentinel node about giving patients information, and I'm very guided by their opinions, and it's very individual. There are people that just are not interested in any more surgery, and it all sounds horrible to them, and I'll just have that wide local excision, thanks very much, and be gone. And then there are others, of course, who, even if that risk of a sentinel node being positive is low, really want everything done and want every opportunity to get drug treatment if it's going to be of help to them. So having an understanding of what it all means is really important.
So there's probably no patient where it's not possible to do a sentinel node, where it's not, it may not be, maybe okay to do a sentinel node biopsy, depending on certain things.
Look,
no one we can refer that. Most of the time.
Yeah, absolutely. Look, you can certainly do technically a sentinel node biopsy on anything. You can inject any normal piece of skin and map a node and take a node out. So, and you can do it for any lesion. What's the thinnest practical melanomas that I'm doing sentinel nodes on? 0.6s, with a feature. So 0.6s in young people with a high mitotic rate. That mitotic rate number seems really important. Like, I'm having the conversation with them. I'm doing them for some of them. Some of them want it, some of them don't. Some of them want a map and then an ultrasound. I guess it's all a conversation. But would I start doing it in 0.5s or 0.4s or 0.3s? No, I certainly those earlier melanomas, I don't think that there are many. That's not in my practice to be.
So they're probably definitely ones that we can be managing in general practice.
Yeah, so 0.2s and 3s, and you can look at the calculator as well if it makes you feel better, but they fall outside that realm. And I mean, look, the guidelines are the guidelines. If your patient doesn't fulfill the Australian national guidelines for who should be considered for a sentinel node, I don't think you can be criticised for doing a wide local and not offering them. I mean, they are the national guidelines. There's nothing that any one clinician is doing that should ever make anyone think that if they're following the guidelines that they're doing something wrong. You're completely, if you're in the guidelines and those patients are not, but at the front line of what's happening in melanoma practice, what we're doing at the Institute, where we're at, where it's all headed, where we're predicting the next trials will show and what's important and what's not, well, this is what's happening. We're having these discussions, and we're tending to have them earlier and earlier than we ever did, because now that we actually have drug treatment and these patients have an opportunity to get those drug treatments, those sentinel node biopsies are kind of more important than ever in a way.
So we've got about a minute. Really quickly, just a quick question. What if melanoma is on large veins or arteries like the jugular or carotid? I suppose we just careful surgery.
Yeah, I mean, like the salvage of neurovascular structures. It's for me, it's do it in an operating room and do it cautiously. Yep. You don't sack. I mean, the wide local excision, the melanoma, we know where it is. You'll have a report. It's only 1 millimeter, 2 millimeter. It's not the tumor itself that's invading those deep tissues. When we're performing a wide local excision, when we're taking out the deeper tissues and the surrounding tissues, what we're removing is the lymphatics around there. We're removing the other melanocytes and pigment cells that were in contact with that melanoma. The reason that the guidelines are what they are is that smaller margins have been associated with more local recurrence, and margins less than a centimeter are linked to survival disadvantage. But So there's no need to necessarily be sacrificing, important vital structures in achieving those safety margins. I mean, there are melanomas that can be very locally advanced. I mean, I've treated, local melanoma that has just grown into skulls and brains and all sorts of things. But that's not necessarily common. And so for the vast majority of your wide local excisions, for the vast majority of your wide local excisions, if an excision biopsy was done, your specimen that you're taking out comes back as, thank you for this normal skin with a scar. And yet it's still a valuable thing, because we know if you don't do that, the local recurrence is high. But no, we're not sacrificing major vessels or nerves when we're chasing, an arbitrary guideline number or depth.
So last question in about a minute. And I know we talked about this a while back in terms of referral.
Yeah.
So, who do we refer to? Do we refer, is it best to refer straight to the Melanoma Institute or to a local specialist? And
sure. Look,
what's the pros and cons of that?
I mean, I think we've got the health pathways talk coming up, and I think that's going to sort of address all of that. I guess as someone who works at the Melanoma Institute, the Melanoma Institute is just to cover it really briefly, is a non-for-profit organization that covers education, research, training, and within it we have clinicians like myself and the other surgeons and dermatologists and everyone, and we're all independent clinicians. And even though you can refer directly to the Institute, you can also directly refer to any given individual within it. And equally, a lot of us have practices elsewhere, like myself at St. George, but other clinicians in the Northern Beaches or Westmead, so we all do work there and above. And so if you're referring it to someone who works at the Melanoma Institute in any format, you're actually linking them with their team, even if you don't send them to the building. You don't have to send it just to the Melanoma Institute. That's just one facility. There's lots of good surgeons and dermatologists and medical oncologists who treat melanoma throughout Sydney. So I guess the point is, like everything, I imagine there are doctors that you refer certain things to, and if you have a referrer, you should feel comfortable, if they're managing things well, to refer to them. I don't think you have to. I mean, our guidelines say that every patient with a melanoma should have an opportunity to be part of an MDT, so you'd want to make sure that the person you're referring to looks after lots of melanoma and has some sort of MDT, but there are lots of MDTs. And I guess the final thing I would say is, there is an advantage in actually having a set referrer that you have a relationship with, because, I have people that refer to me. I work closely with dermatologists and GPs, and as do my colleagues. And, we are very happy to chat to people if they're uncertain about stuff, and, short of sending patients along. So I think you get a lot of benefit when you work closely with clinicians. I mean, I work closely with the pathologists I send my specimens to, and the medical oncologists. And when I see something challenging, I call them, and then I get feedback from them about what's happening. So, building a relationship with someone is a good thing. Anyway, but the health pathways is going to be really good, because they'll give you an update about where that's at with the local, Southeast area referral pathways and the sort of things that are happening, I think.
Yeah, thanks, Michael. Thanks for your talk. It's very thorough, and giving us lots of food for thought.
So I'm Dana. I'm a GP that works with the Southeastern Sydney Health Pathways team, and I'll just very briefly talk about health pathways. So in this PHN, we've got Southeastern Sydney Health Pathways and the Sydney Community Health Pathways, and they're supporting care 24/7. So on the screen here, we've got the URLs that you can use to access health pathways, and you can also see QR codes there. And we've also got the login details on there, and because both of these health pathway teams are in the same PHN, you can use either login details for either of the health pathways. So Southeastern Sydney is covering Prince of Wales, St George, Sutherland, St Vincent's and Sydney Children's Hospital, and Sydney Health Pathways is covering RPA and Concord. So we're really excited at Southeastern Sydney Health Pathways to have just recently published our melanoma pathways. So we have suspected melanoma, established malignant melanoma, melanoma follow-up, and also this specialist melanoma assessment pathway, which covers a lot of the referral pathways that Michael briefly touched on. So when you access these pathways, these are clinical ones. Will give you information on if you're suspecting melanoma or once it's been established. And then if you're wanting to get extra assistance on who you would refer to or who you would seek advice from, the specialist melanoma assessment page is useful. And in those pathways, we also have links to the Melanoma Institute of Australia risk calculators that were mentioned and the Cancer Council guidelines. And there's also some GP modules that the Melanoma Institute of Australia have put up for you to access. So there's links to those as well. And then Sydney Community Health Pathways, who've been around longer than us, have a number of useful pathways as well. So they have the pigmented skin lesions pathway, the skin lesion excision, and then also the urgent dermatology and melanoma assessment pathways. So we've got our contact details here. And feel free to get in touch if you have any questions or any feedback. So if you wanted help with how to access the pathways, how to use them, we've got the contact details here. And also if you've got feedback, so things that you think we could do differently or pathways that you'd like to see us publish, then let us know. So thank